morning, and welcome to Medicine Grand Rounds. It's really my pleasure to introduce today's Grand Rounds, where we have two speakers. I won't do either of them justice in terms of their many accomplishments, because we do want to get on to their presentations. The first is Tom Raife. Tom is a graduate of Iowa State University and the University of Iowa College of Medicine. He then stayed in Iowa City for residency in clinical pathology and then fellowship in transfusion medicine. He stayed on briefly at the University of Iowa and then went to the Medical College of Wisconsin in a junior faculty role, then moving back to the University of Iowa in 2001, where he went up through the ranks to the rank of clinical professor, a medical director of the DeGowan Blood Center, and transfusion medicine fellowship program director. He is currently the director of transfusion medicine services here at the University of Wisconsin, where he arrived back in 2014, and is a professor in the Department of Pathology and Laboratory Medicine. He's received a number of awards over the years, including the American Association of Blood Bank Scholar Award. He's received various grants and sponsorship for clinical trials. He's published over 50 publications in this field and has given many talks throughout the country. Our second speaker is Scott Wilson. Scott is a member of our faculty. He took his undergraduate degree at Fairfield University and then attended the University of Osteopathic Medicine and Health Sciences in Des Moines. He went on to a one-year internship and then was recruited to our residency. So he's an alumnus of our residency program, finishing in 1990. He went back to Des Moines through the year 2000, and then he also was called back to the University of Iowa. There's a little bit of a theme here for these two, where he started out as an assistant professor and rose through the ranks to become a professor at the University of Iowa. He was also associate director of the Division of General Internal Medicine and director of their hospitalist program, and he's currently a clinical professor in the Division of Hospital Medicine in our department. He's really well regarded as a teacher, winning several teaching awards, including being nominated for the M4 Teacher of the Year award back in Iowa before he left, and we recruited him back to Wisconsin. He's also listed over several years in the Best Doctors listing. Today, these two are going to provide us education on a very important topic, blood management at the University Hospital, conservative versus liberal. Let's start off and welcome Dr. Raife.
Thank you very much, Dr. Page. Everybody hear me okay? Okay, great. As Dr. Page was mentioning, Dr. Wilson and I both practiced at University of Iowa hospitals and clinics up until about 2 years ago or so. We both came here, and both of us were integrally involved in patient blood management activities there, which was a very robust program. And it's by virtue of that activity and then the activities we brought here that we come to you today to talk to you on this topic. This is Dr. Wilson's disclosure slide, and this is my disclosure slide. Okay, and there's the obligatory reference to the election cycle here. And indeed, you will get a chance to vote during my section of the talk here in a few minutes, so prepare your hand to raise. All right, so learning objectives for today. We want you to be able to, in particular, define patient blood management. And this is really the catchphrase for an initiative that is going on at hospitals all over the country now. And it goes by the term patient blood management. And we probably thought that many people here may not even be familiar with that term. So that's a big part of what we want you to do and understand that. We want you to understand current RBC utilization at university hospitals and how it relates to our peer institutions. So for that purpose, we'll be showing you benchmarking data. We want you to understand literature, and Dr. Wilson will be showing you that, and also to use how we use electronic tools in patient blood management. Everybody is familiar with the term primum non nocere, which means first do no harm. And so I'm going to start with a clinical scenario. And I'll just read this to you. A 78-year-old female with a history of insulin-dependent diabetes, coronary artery disease, hypertension, hyperlipidemia, urinary tract infections, hypothyroidism, was transferred from a community hospital in Iowa City to the University of Iowa Hospitals and Clinics on March 30th, 2009 for repair of multiple orthopedic injuries that resulted from a fall. She actually was out to lunch with her daughter and did a face plant in the parking lot of the local bagel shop, and she was transferred to the other hospital in town, and they kept her very shortly and decided it was too complicated and moved her to University of Iowa. On the evening of March 31st, which was the next day, she had a hemoglobin of 9.2, and I will emphasize some of the lab values as we go along here. At that time, 2 units of red blood cells were ordered by the surgical resident. In the blood bank, the antibody screen was conducted. It was negative. So 2 units of red blood cells were dispensed by electronic cross-match, meaning that no serological cross-match was performed. The computer does the cross-matching in that case. Before her transfusion, her temperature was 37.3 degrees, so it was normal. First transfusion was completed about 8:40 p.m. At that time, her temperature was up to 38.7. Second unit was then completed just after midnight the next day, at which time her temperature was now up to 39 degrees centigrade. The family and the patient complained to the nursing staff that the patient was not feeling well at all during the transfusions. The nursing staff consulted with the ordering physician, the resident who ordered the transfusions, who attributed the fever to probable urinary tract infection. The blood bank was not notified of a possible transfusion reaction. So at 7 a.m. that day, the patient underwent surgery, which was complicated by hypotension, decreased urinary output, and lactic acidosis. Because of these complications, the surgery was stopped. The patient was transferred to the surgical ICU. During the next 3 days, she remained seriously ill. She developed renal, hepatic, and pulmonary failure. Her hemoglobin decreased from its peak right after the transfusions of 10.8 grams per deciliter down to 7.8 grams per deciliter 3 days later. And at that time, a second antibody screen was ordered because the sample had expired in the blood bank for additional transfusions. So that second antibody screen done on April 4, 2009 was positive, which is unexpected considering it was negative 3 days before. And anti-Duffy A was identified in the plasma, as is the workflow there and here. The sample from 3 days earlier was retested and now found to be positive for anti-Duffy A. The 2 units that were transfused on that evening were both Duffy A antigen positive, as it turned out. So that indicated that both transfusions were incompatible. So the blood bank had had a false negative result on the antibody screen and issued 2 incompatible units to the patient. The patient remained seriously ill, and the family elected to withdraw care on April 6, 2009. After supportive care was withdrawn, she expired at 9:43 a.m., and the FDA was notified of a possible transfusion-related fatality. This began a rather difficult and long process for us and me professionally. Investigations were conducted, external investigations by the FDA, by the Centers for Medicare Services, by the American Association of Blood Banks and College of American Pathologists, and the Iowa Department of Inspections and Appeals. Internal investigations into the possible source of the error did not determine the cause for the false negative antibody screen. We did, however, identify one other sample tested that day that also had a false negative result. So, in the end, unfortunately, the decedent was a matriarch of a very prominent family in eastern Iowa and a benefactor of the University of Iowa Hospitals and Clinics and Cancer Center. And a year later, the hospital negotiated a 7-figure settlement. So the lesson that is to be gained from this episode is that despite the fact that we transfuse more than 35,000 units of blood at this institution every year, and I would gather for most of you things go quite smoothly by and large. Every once in a while something goes very badly wrong, and that needs to be taken into consideration every time a transfusion occurs. So these are the questions. This is the voting part of the talk. So many things might arise in one's mind in hearing this story. A few of them I've listed here. First question, should the patient have been transfused preoperatively? The hemoglobin was 9.2 and her condition was stable. So for those of you who vote yes on this, please raise your hand. There's one. And for those of you who vote no, please raise your hand. And then there might be some abstainers as well. So there's an abstainer up there. Okay. So a follow-up question, in the event that one thinks maybe a transfusion might have been warranted, I guess, would be, would 2 units be warranted in a case like this? If you think yes, raise your hand. I think we're down to 0 responses there. If you think no, raise your hand. Yeah, okay, very good. Were the transfusions managed appropriately? Scenario of a fever rising from 37.3 up to 39 degrees centigrade. No transfusion reaction was called or reported. So if you think yes, raise your hand. Think no? Yeah, I think that's a majority opinion. Was the patient actually stable enough for surgery at 7 o'clock in the morning? Yes? No? Yeah, well, so I can tell you that the resident's note that morning when she went on rounds before surgery was that there were no acute events overnight. Patient reports no problems, is neurologically intact, looks good, and ready for surgery. Okay. Patient blood management definition. So patient blood management, again, is by catchphrase, I should say, for initiatives that are happening in hospitals all over the country. This is what patient blood management is. By definition, optimizing the care of patients who may need a transfusion. So the idea here is that there could be many patients in any hospital who might or might not need a transfusion. Patient blood management is the judicious decision-making that considers the possibility of a transfusion, weighs the possible benefits against the risks, etc. It's evidence-based. I would argue that of all parts, certainly of transfusion medicine, it is the most quintessentially evidence-based piece of our work that we do, as Dr. Wilson will show you in a minute. It's very much multidisciplinary. It includes things like appropriate indications for transfusion, establishing and adhering to those indications, and also appropriate dosing of blood products. The goals of patient blood management are to improve outcomes by minimizing exposures, for example, optimizing transfusion triggers, or in the case of our institution, we use targets as opposed to triggers, with the idea being that rather than having a threshold below which one transfuses whatever amount one decides, think about an actual target for where you want that, let's say, laboratory value of hemoglobin or hematocrit to be, which encompasses the idea of dosage as well as a decision to transfuse. Treating anemia and coagulopathy, I can tell you that in 2008 or so, a survey at University of Iowa hospitals and clinics of elective surgeries showed that about 30% of people coming in for elective surgery are anemic, mostly iron deficiency anemia, which is a big cause for, of course, perioperative transfusion. So treating that anemia is now a very important part of patient blood management in many institutions. Treating coagulopathy, obviously. Minimizing iatrogenic blood loss, also a part of a project of patient blood management at University of Iowa in the surgical intensive care unit when they looked at how much blood they were drawing on a daily basis. It averaged 11 tubes of blood per day per patient. They managed to get that down to 4 tubes per day per patient just by organizing their lab ordering. 11 tubes of blood per day is about a third of a unit of blood. So significant iatrogenic blood loss. Improving outcomes by increasing hemovigilance, eliminating patient identification errors. WBIT stands for wrong blood in tube, one of the most feared things in transfusion medicine, hanging an ABO incompatible unit on a patient who has been misidentified at any step along the way. Recognizing and reporting transfusion reactions. We just saw an example of how that is a critical part known as hemovigilance. Improve outcomes by ensuring the blood products are available for patients who need them. In other words, save critical components like, say, type O negative blood for people who actually need it. And of course, doing all that saves costs. Let's look at some benchmarking data for UW hospitals. So benchmarking data, we've been grinding over this for almost 2 years now in our working group. We look at it from a couple of points of view, and this is what you'll see in the literature as well. One is the frequency of transfusion, and in this case what we do is look at what percentage of all inpatients receive any kind of transfusion. And I don't know if you can imagine where that number stands, but I'll show you in just a second. Is it 10% or 20 or 50% of patients? We'll see. The quantity then per patient transfused. So when we elect to transfuse a patient, how much blood do we use? What's the dosage that we use compared to our peer institutions? And then when you put those two factors together, you get the total blood use per inpatient discharge. So that's the data I'm going to show you. All right, so the red bar is our hospital, and this is our peer group that we compare ourselves to. So this is established by hospital administration for a variety of purposes. This is actually a subset of our peer hospitals that was derived by looking at those who had the closest case mix index to our hospital, sort of as a measure of complexity and resource utilization. So these are our neighbors with respect to that metric, and also our peers. And you'll notice down here that University of Iowa is the leader, so to speak, in terms of the fraction of their inpatients that actually get any blood product at just under 10%. Now, when we started patient blood management at University of Iowa, that number was almost 15%. So over the last 5.5, 6 years, they've reduced that significantly with their patient blood management. And in fact, our hospital here at about 12.5% is down from where we started, close to around 14.5% too, 2 years ago, just by virtue of increased awareness, I think, of what we've been doing with patient blood management. Here's a time-dependent look at that same data, starting down here at, this is the fourth quarter, would be October through December of calendar year 14, up through, this is April through June of this year. So these are quarterly data. The blue represents the mean value of percent of patients transfused in our peer group, and this is our data. So you can see that at the beginning of our project a couple of years ago, we were well above the mean with regard to our peer group. In fact, we were at about the 75th percentile. So we knew we had some work to do. What I like about this is that we have, I think, a convincing negative trend over the last 2 years, and in particular the last 2 quarters. That trend is decreasing, which puts us down here below the mean. So that's frequency of patients transfused, about 12.5% in this institution. Now, when we choose to transfuse patients, how much blood, this is red blood cells, how much blood do we actually give? Here is where we have work to do. We're above the mean, and although this number is actually improved as well compared to our peers, it still has work left to be done. So and you'll notice down here, University of Iowa is one of the leaders in this area as well. So we use a little over 4 units per inpatient who receives blood transfusions. University of Iowa is down here around 3.5 units. So that adds up. If you look at the difference between this bar and somewhere down here in the lower quartile, it amounts to about, in terms of the acquisition cost of blood, just looking at a cost, about $600,000 worth of blood between here and down here. This is the time-dependent data, and you can see that we've been pretty consistently above the mean in this regard. So while we're judicious, getting increasingly judicious about who we transfuse, when we transfuse, we're very generous with our use of blood. So, how does that come together in terms of our overall blood use per inpatient discharge? This is where we are, a little bit below the mean here, or the median, I should say. And so that's a good place to be. And I think that we feel in our working group that we'd like to move down here into the lower quartile. This is our overall trend. So up until the last couple of quarters, or actually this quarter, we've been above the mean with respect to overall red blood cell usage compared to our peer groups. And in the last quarter, we dipped down here, so we'll hope this trend continues. So our interpretations, UW is increasingly judicious in determining who needs a transfusion, but when we transfuse, we do use more blood than needed.
So I'm going to show you a few of the studies that are available now, and then I'm going to show you what we're doing here at UW. These are studies that look at the outcomes at various levels of red blood cell transfusion triggers. There are now, these are randomized controlled trials that we're going to look at, high levels of evidence. There are 31 studies to date. We're not going to look at all those today. We're just going to look at ones that are pertinent to our department. And these are studies that randomize patients into triggers around 7 or 8 grams of hemoglobin, depending on the study, or higher levels of hemoglobin around 9 or 10 grams. The first one is called the TRICK trial. By show of hands, chance to vote audience participation again. How many people here have heard of the TRICK trial? And this is not the trick trial, not the, there's no trick to this. This is not the trick or treat trial. We're not getting into the Halloween theme here. The TRICK trial is really a landmark trial in transfusion practice. This is a critical care study. This is almost 17 years old now, and this is when things really started to turn in transfusion practice. This is a study in ICU patients, over 800 patients, randomized to restrictive or liberal transfusion triggers. The restrictive group had a goal of 7 grams of hemoglobin, and the liberal group had a goal of 10 grams of hemoglobin. And you can see there the primary endpoint was 30-day mortality. And the endpoints were 18% or 23% respectively, and those were not statistically significant. Here's the Kaplan-Meier curve for all patients. They look like they're diverging, but the p-value was 0.10, so they were not statistically significant. But then when they subgrouped the patients, those with Apache scores of less than 20, these are Apache 2 scores, we were still using the Apache 2 back then, they did diverge, and those with the liberal transfusion strategy, the higher level, transfused to the higher level, did worse with a good p-value. Those who had the restrictive transfusion strategy had a better mortality, better survival. And those who were younger patients, less than age 55, also had a better survival when they received the restrictive transfusion strategy, again with a good p-value. So we're starting to see a theme emerge here that the patients who are healthier, less ill patients, or maybe with a better underlying milieu, were better when they had less blood transfused. And we'll see that emerge from some of the other studies as well. The next study was done in septic shock patients. This is a multi-center parallel group study done in Scandinavia. About 1,000 patients in ICUs and multiple institutions. And these were randomized to either 7 grams or 9 grams of hemoglobin. They were given red cells in 1 unit multiples, and this becomes important instead of some studies were given 2 units or higher levels at a pop. And the primary outcome measurement here was 90-day mortality. So you may know in Scandinavian countries they have very good registries, so they were able to track the patients outside the hospital. And this particular graph shows the levels at which the different groups were actually transfused. So in the upper graph shows the higher hemoglobin threshold and the lower hemoglobin threshold. And I'm showing this to show you that even though there was some divergence within the group, there was no overlap. So they were able to, the researchers, the study personnel were able to keep the two groups separated in terms of what transfusion levels they were able to give. In addition, we're showing that the blue group, this was the conservative group. The restrictive or conservative group is shown in blue. And, you know, in this time right now, the blue states are usually the liberal states. So we're showing that we don't have any political bias here. You know, we had to get some special permission from several offices at the university to use this title for our talk today, Conservatism versus Liberalism. Just trying to give a catchy title there. So these are the results. In the restrictive group, they received a median of 1 unit of red blood cell transfusions, and in the liberal group, 4 units. And the mortality rates were 43% and 45%, so not statistically significant difference. So there was no difference between the two groups in terms of mortality. Here's the Kaplan-Meier curve. And then there were some secondary endpoints they looked at as well, and they were similar in both groups again. So ischemic events, including strokes, myocardial infarction, bowel ischemia, and limb ischemia, no difference. Requirement for life support, including mechanical ventilation, renal replacement therapy, and pressors. And then it turns out that adverse reactions to the blood transfusion themselves did not differ between the two groups. There was actually only one adverse reaction to the blood transfusions. Now, blood transfusion reactions are rare in general, so we could say that the study was not powered to detect those kinds of transfusion reactions. But the point is that giving additional blood transfusions did not counterbalance the benefits that were lost by the patients who received the blood transfusions, the excessive amounts of blood transfusions. The next one is a randomized control trial in severe upper GI bleeding. So this will be of special interest to members of the audience who, gastroenterologists, critical care folks, and hospitalists who deal with this every day. So this one's over 900 patients in a single center in Spain, randomized to levels of hemoglobin of 7 or 9 grams. And they also stratified these patients for the presence of cirrhosis. There were actually in this study, 55% of the patients in the restrictive group and 14% in the liberal group did not require any transfusion. And the 6-week mortality in the restrictive group had a relative risk of 0.55 for mortality. So here's the Kaplan-Meier curve. So on the on the outside, on the upper part, is the Kaplan-Meier curve that has to be shown by convention in publications. But we've shown on the inset a blow-up version of it from 90 to 100% on the overall survival, and then constricted the number of days, the 45 days, just to emphasize how the curves diverge. The liberal strategy really shows how their survival was worse for those who received the liberal strategy. So the patients who received the liberal blood transfusions at to bring them up to 9 grams of hemoglobin did worse with a good p-value. Here's the hazard ratios. You can see the overall hazard ratio at the top with a good p-value favoring the strategy. And then I wanted to show the child puke class A or B patients here with a good p-value. And then what happens when they subgroup the child class C patients, they lose that advantage. So again, we're seeing the patients who are healthier, so to speak, less ill patients really were much more favored with the restrictive strategy. And lastly, I'm showing this Cochrane review. When Dr. Raife and I started preparing for Grand Rounds, we were using an older Cochrane review. And the Cochrane reviewers conveniently published last week an update on this. So this update includes 31 randomized controlled trials, over 12,000 patients. And in the restrictive groups, they were 43% less likely to receive a transfusion. They overall received 1.3 fewer RBC units per patient. And all of them, if you look at the way over on the right-hand side, none of the differences were statistically significant. That's including thromboembolism, heart failure, stroke, 30-day mortality, myocardial infarction, rebleeding when they looked at that, and pneumonia. Now, the relative risks were all but myocardial infarction were, we want to make them look, they're less than 1, but by the strict Cochrane criteria and by our statistics, we'd have to say they're really not statistically significant. So at least, the blood transfusions in the restrictive and liberal groups were the same. Both groups are the same, and by giving more blood, we're at least wasting resources and exposing the patients unnecessarily. So in summary then, the age-old hypothesis that red cell transfusions, probably what I was taught and many of you were taught, the delivery of oxygen to cells and tissues and avoiding deleterious oxygen debt in critical circumstances in ill and injured patients may be outweighed now by the immunosuppressive and microcirculatory complications of red cell transfusions. We're starting to learn about the complications in the laboratory and in humans that are occurring during red cell transfusions. And this is where the idea that if a little bit of something is good, then more must be better, that's where this theory fails. So some of the problems that we're facing here at UW, we continue to transfuse patients at higher hemoglobins or hematocrits than is necessary, and we continue to do these 2-unit orders in stable patients. So some of the things that we've done here at UW, we've made some changes to the blood transfusion guidelines. We've made some changes to the 2-unit ordering practice, and we've added a decision support tool that's now embedded in the blood order. The changes to the blood transfusion guidelines have gone through the process through the various committees and stakeholders. This changed the target laboratory, changed to targets rather than triggers. So Dr. Raife mentioned this, and this is just a little bit of semantics. So we use the word targets to mean that we're transfusing up to a target, and we're incorporating the guidelines. So in other words, you see a hemoglobin of 7 instead of see a hemoglobin of 7 and transfusing whatever number of units you want, and that brings them up above 7. Now we're going, now you're going to see, okay, I want to get them up to 7 now. And we're going to give you how much blood it takes to get them up to 7. So we're transfusing to a target instead of down to this so-called trigger. And these targets include red blood cells, platelets, and plasma, cryoprecipitate, both for adults and pediatrics. So the next change idea was to reduce the 2-unit ordering. So we removed these so-called radio buttons, 2, 3, 4, etc., that you were able to see before, and we pre-selected 1. So now in certain orders you'll see the radio button 1, and that'll be sort of a nudge to say, okay, I'll pick 1. And we updated the indications to match the blood transfusion guidelines, which I'm going to show you here in a minute. And then we required a comment. If you select other, then it requires a comment. So these are the results of those interventions. On the top bar graph, this was before the intervention was made in February of 2000 this year. So before the intervention, people were ordering 1 unit at a time, a little over 600 times in a 2-month period. And over 1,000 times, people were ordering 2 units at a pop. And then after we flipped the switch, ordering 1 unit at a time, a little over 2,000, almost 1,100 times in that 2-month time period, and then 2 units at a time, 900 times. So we sort of inverted these 2 bar graphs. The rest of them are about the same. Those are other numbers of orders at a time. The next change idea was to put this electronic decision support tool in place. And this is a blood utilization calculator. We call it the Buck. We tried to get Bucky in there, not Buckeye, but Bucky. Buck was as close as we could get, and we're sticking to that. So this is how we transition from the transfusion trigger to the transfusion target that I mentioned. This calculates the minimum number of units to reach the target. It's a decision-making process based on indications and patient data that's drawn from other places in HealthLink. So there's a bit of math that's behind it. So this is a screenshot of the Buck, it automatically suggests the appropriate number of units depending on what indication you pick. So if you're picking R3, you want to get up to a hemoglobin of 7. For this patient, the patient's hematocrit is 19, and the patient is 80 kilograms, it's going to select 1 unit. So if you hit that button, it's going to push 1 unit over into the right-hand column where the orders are. If you selected R5, which is the myelosuppressed patient or the acute coronary syndrome, it's going to need a hemoglobin of 8. It's going to push 2 units over into the order column. In the next example, the hematocrit is 21%, or a hemoglobin of 7, and the patient is 80 kilograms. So if you selected R4, that's a stable, non-bleeding patient, it's going to give you a message that the patient doesn't require any blood. So you're going to just check that box. So future directions. We are about very close to going ahead with a Buck for platelets. So there'll be a decision support tool for platelets. We'll follow soon after that with plasma and cryoprecipitate. We're also in the process of a provider clinical practice data that will be available to every practitioner. It's called ClickView, and for this you'll be able to view your own practice, your blood ordering practices. And this will also be available to department chairs and clinical practice management personnel to see how much of different types of blood products you order and over what periods of time. Next thing that we can do is a preoperative anemia management, and Dr. Raife was kind of indicating that. Just to kind of lay that out for you briefly, the way this would look would be to find groups of patients that are scheduled for elective surgery and look at heavy hitters. So patients who are known to have a lot of blood loss during the time of surgery, like cardiovascular surgery or gynec surgery, and then overlap that with patients who are known to be likely to be anemic before surgery, like colon cancer patients. We know they leak blood before they're diagnosed. And take those patients and do hemoglobins when they're in the pre-op phase. And then take those, if those patients are anemic, bring them into a clinic and do a focused history and physical and some appropriate lab on them. Maybe this would be done by a physician assistant or nurse practitioner. And then, if it's appropriate, if those things pan out, and if it's appropriate, give iron and erythrocyte stimulating factors and try to get their hemoglobins up before surgery during that 2 to 4 week window before a surgery occurs, and keep them from requiring blood transfusions during or after surgery. So this has been a successful strategy for reducing the amounts of blood transfusions that patients need. The next thing that we can do here is reducing iatrogenic blood loss. As Dr. Raife mentioned, there are a lot of blood draws that occur in critical care settings, for instance, and other places in hospitals that can be better coordinated and reduced to pediatric tubes and other things that can be done. We know now that patients become anemic from blood draws in hospitals. I know many of you may have been told, like I was, that patients keep up, their bone marrows keep up with all the blood that we draw in hospitals for patients who are critically ill or chronically ill in hospitals for prolonged periods of time. But it's been proven now that patients become anemic and they may need blood transfusions along with other reasons for their blood loss while in hospital. The blood that we draw from them may augment this type of blood loss. So there are some horizons there. And lastly, there are further horizons that we can cross in transfusion safety itself. So we've got a few minutes left. I can go one more step with you on this. So I think it's clear, everybody in this room, if there's something you could do to help your patient, we would all do it, of course. And I'm just going to branch, if we all know, we give aspirin to patients to prevent myocardial infarction or stroke, ACE inhibitors for heart failure. But the fact is that we don't all do that. And there are many programs in place, there are core measures, reminders for us, a lot of different things that we need to help us with that. So I'm going to branch for a minute and think outside the box for a minute. And, this is a Big Ten university, so we're going to talk about sports. And this always comes up, seems to come up when people come here to speak. So, which player played the greatest game of basketball ever? And you can just think about that for a minute. You might be thinking about players who are in the league now or recent players in memory. But you might think about this guy. Anybody know who that is? Wilt Chamberlain. Thanks, Dr. Mackey. And with apologies to Malcolm Gladwell, some of you may like to read Malcolm Gladwell's books or listen to his podcasts like I do. And he has a piece about Wilt Chamberlain. And Wilt Chamberlain played in this game. Malcolm calls it the greatest game of basketball anyone has ever played. In Hershey, Pennsylvania, March 2nd, 1962, the Philadelphia Warriors versus the New York Knicks, in which Wilt Chamberlain scored 100 points. Nobody else has ever done that. And Wilt Chamberlain was 7'1", 275 pounds. He averaged over 50 points a game. He was a force to be reckoned with. He could shoot over people. He could touch the baskets, the rim, standing flat-footed. He was an amazing player, but he was a terrible foul shooter. If you want to defend against him, what would you do if you were a player or a team or a coach? If you want to defend against him, you would foul him. Just foul him, and he would go to the foul line, and he would miss. But during this season, he learned to take care of that. He learned how to shoot the free throw, and he shot underhand, the granny shot. And during this game in which he shot he made 100 points. He made 28 free throws. It was the most in NBA history. The granny shot, if you think about it, foul shooting, nobody's defending against you. You just have to concentrate. You can practice 800 or 1,000 free throws a day, and you can get pretty good at it. You just have to kind of block out the crowd noise. And your arms are down low. People don't walk around like this all day. Your arms are down low. It's kind of natural, and you can figure that out, and Wilt Chamberlain did. He had a great year, scored 100 points in that game. And his coach actually told him, we may never lose. If you can keep shooting that foul shot when people foul you, we may never lose, he said. Can you imagine that? But the next year, what happened? Wilt Chamberlain went back to shooting overhand. And he went back to shooting terrible from the free throw line. Inexplicably. Nobody knows why exactly he did that. Maybe it was peer pressure, or it was too embarrassing, or nobody knows why exactly. So I've been noticing that with this blood ordering thing, my peers, our residents, and even I feel it myself, there's this draw to go back to this 2-unit ordering thing. And with patients, there's this tendency to say, oh, this one patient, I want to get that hemoglobin up to 8 to 9. Even though there's this weight of data that says it's not necessary, it's maybe worse for the patient. In some settings, we know it's worse. It's at least a waste of resources. But in certain patients, it might be harmful to them. So I leave you with that picture. I leave you with that thought. I leave you with that statement. We may never lose. We may never lose. Our patients may never lose if we'll stick with what we know is right and what is good for our patients. So that's it. Thanks.
Questions? Thank you.
Thank you very much. I'll ask our speakers to call on the audience and please repeat the questions. I will make note, I got to say, I could never force myself to shoot underhand either, but I wasn't much good overhand. But we all, looking at our CVs, went through a time when there were rules you learned as an intern. And one of the rules I learned is if you're going to give blood, give at least 2 units, and that's completely wrong. So a lot of what we learned was wrong. I'll ask the speakers to call in the audience, and again, please repeat the question.
Thank you, Dr. Page.
So you better call on.
Yes, I was wondering if there's any controlled data about the use of platelets sort of jumping ahead, particularly in patients with central nervous system disease, where platelets drop out, and what the target should be, and as a corollary to that, what the corollary should be for a central nervous system patient going to surgery, what minimum platelet count you want. Currently, the neurosurgeons want 60 or 70,000. So, or sometimes 100.
I don't think there are any data.
So,
Two different scenarios. Central nervous system disease, what should the target platelet count be, and then if the patient's going to surgery?
so the question was, are there data that support a minimum platelet count in a patient with central nervous system disease, or one that's going for surgery, in particular neurosurgery, I think is the scenario. Dr. Wilson and I would say, Dr. Williams is back here too. I'm not aware of any data to support that. The scenario in particular of, at least where I practice at University of Iowa and I think elsewhere, for neurosurgical procedures or surgeries in closed spaces, the platelet count, or the target platelet count for those patients preoperatively is 100,000 platelets per microliter, and I'm pretty confident in saying that that was sort of pulled out of the clear blue sky long ago and has been promulgated as just sort of practice, standard practice. Any thoughts on that, Dr. Williams?
I completely agree. I don't think there's any evidence to support that number. You're never convinced them of that.
And the other scenario, a patient with thrombocytopenia and, say, glioblastoma, what target?
I'm almost 100% confident there aren't any, high-quality randomized clinical trials that support any kind of platelet target in that realm either. And so, I think that the notion of a platelet count of 50,000 per microliter is at least predicated on old data. about platelet counts from 50,000 down to 0 and bleeding tendencies and bleeding time and et cetera. So there's some rationale to that practice of trying to get a platelet count up to 50,000. Is that fair to say, Dr. Williams?
Yes.
And so, but in terms of central nervous system malignancies, disease, et cetera, and particular platelet counts, I'm not aware of any data to support that.
Dr. Mackey.
This is very interesting because the data, a little is good, a lot is better, is not true. It's really been showing to be true for hyperoxia. Recent studies, I mean, not only recovering from cardiac arrest have much poor cognitive outcome with high saturations, high VO2s, but also even critical care patients, it's turning out you got to pay attention to saturation because there's an increased mortality. Just Scandinavian study this last week showing that. But what I want to ask that has troubled me as an intensivist for a long time is I think the evidence is becoming increasingly that packed red cells are good for people. They immunosuppress you. The bank blood that a lot of blood banks provide, red cells are often a lot further, maybe dead. And it's immunosuppressing. And would we be better giving fresh blood? We obviously don't do that for logistic reasons because bank blood does not increase oxygen uptake very much or oxygen delivery. Could you speak to that issue?
Sure. The question is, what is, I guess, the current knowledge about the age of red blood cells vis-a-vis their clinical effectiveness? And I would say it's, at least in my world, it's a raging controversy. There are, I think, now 4 randomized clinical trials that have been published in the last 5 years or so, comparing outcomes in patients in a variety of settings, both pediatric and adult, when the patients received either, quote, fresher blood, like less than 2 weeks of age, versus older blood, more than 21 days of age or something like that. And those have been, the outcomes are equivocal so far. So we really haven't found a signal in those kinds of studies that shows that older blood is demonstrably worse than fresher blood. But I just returned from a meeting at FDA on this very topic about a week and a half ago, and there are a number of prominent investigators who are looking at a variety of scenarios, both animal models and other kinds of models, considering a lot of other outcomes besides just survival, blood flow, viscosity, and et cetera. And I think that there is quite a bit of data that, in fact, there are adverse outcomes in allogeneic transfusions, and probably relating to the age of stored blood. And so my, I guess, overall response would be that I think it's a work in progress in trying to understand the toxicity associated with red cell transfusion.
Maybe adaptive and homeostatic.
Absolutely.
Yeah. Ann, did you? Ann.
So a couple of comments. I love the order subs that you showed. So in outpatient medicine, we struggle a lot when we do a transfusion and the whole process.
Yeah.
Quite time consuming. It'd be awesome to have an order set available to us to help us get used to that new pattern. And often we don't have access to that. The second thing you talked about, the GI center having a visit to help prevent transfusions in these patients. So those would be common patients that we would see trying to get ready for a colonoscopy, watching their counts drop and trying to be patient, trying to gauge whether they're going to need a transfusion. So if you come up with a process that you think will be really good, share it with the primary care physicians. We could also do that, save a little visit with another person in the GI clinic. I would love to give them some medicine to prevent the transfusion and watch them for the procedure.
Good. Those are suggestions about moving the transfusion protocols to the outpatient realm. Good. Thanks, Ann. Yes.
I assume most of these studies were done in medical patients with anemia levels that developed historically in a period of time. Do you make
Yeah.
any distinction between somebody who had a relatively acute blood loss and maybe a period where, for example, like what you got bleeding, where the bleeding was completely stopped, but then he may not have adapted
Yeah, absolutely. So the GI study, the GI bleed study that I showed were severe acute GI bleeds, and so they presumably came to those lower hemoglobins fairly quickly. The other two studies were more chronic settings, but I did not delve into traumas or other settings where you'd be concerned that the hemoglobin that was drawn did not reflect the reequilibration, so to speak. So those would be kind of off the table. But yeah, I think patients who arrived at those lower hemoglobin levels have adapted to those, and maybe we could go even lower. So that's a really good point. I'm sorry, I didn't repeat the question, but the question was about whether these studies were derived from patients who had gotten to those lower hemoglobins fairly quickly or not. Yeah.
Yes.
Any others?
I'm just wondering why we don't use pediatric tubes as a default for everyone. If it's adequate for kids, why not for adults?
Yeah, we're going there. Totally agree. The question was about why don't we use pediatric tubes more in places where that amount of serum or plasma could be appropriately used for the test. Yeah, absolutely. Good point. In the back.
Yes.
The trick study showed that there could be a difference between over 55-year-olds and under 55. Did the Cochrane review reflect on that, or does your calculation reflect on the geriatric population?
The question was the trick review, the trick study subgroup patients by age, and whether or not the Cochrane review did or not. The Cochrane review did not split patients by age. I guess they did not find enough data in their study pool to do that, and there were no studies that I could find that adequately addressed the geriatric population. Really good question. Thanks.
Okay, if there are no further questions, I want to thank the speakers for an outstanding grand round.
Thank you.